My name is Dr. Sushant Mane. I am an associate professor in the Department of Pediatrics at Grand Medical College, JJ Group of Hospitals, Mumbai, and I am the subject expert in the National Technical Expert Group, National TB Elimination Program, India. So, pediatric tuberculosis, if we talk about TB in children, basically the TB is of two types. We have one which affects the lungs, which is the pulmonary TB, and other one which affects organs other than lung, which is known as extrapulmonary TB. The most common type of TB, what we see, is the pulmonary TB which affects the lungs. And the symptoms of pulmonary TB are the child may have fever which is running for at least for a period of 2 weeks or more. The child would be having cough which again is lasting for a period of 2 weeks or more. The cough could be of any type, either a dry cough or a wet cough. And third, the child would be having loss of weight, or the child would not be gaining adequate weight as a normal child should be gaining. These are the symptoms of pulmonary TB. If we talk about extrapulmonary TB, the commonest type of extrapulmonary TB, what we see is a lymph node TB, where the child would get swellings in different parts of the body, the most common being swellings in the neck. Then TB can also affect the brain, it can also affect our abdomen. So depending upon which organ is involved, the child can present with different symptoms. For example, a child with a brain TB can present with seizures, it can present with headache, the child can present with vomiting. A child with abdominal TB can present with pain in the abdomen, distension of the abdomen, and all these features. So if we talk about diagnosis of tuberculosis in children, when we talk about pulmonary tuberculosis, the test which is done is the test on the sputum, which is produced as a result of the disease in the lungs. Now, as children are very small and are not able to give out sputum, in children up till the age of 5 to 6 years, a gastric aspiration is done. That is, the sputum is retrieved from the stomach of the child and that is tested. For a child more than 6 to 7 years who is able to cough out the sputum is collected and sent for tests. Now, what tests are done on the sputum is there are molecular tests which are done on the sputum, which is known as a gene expert or a CBNAT, which will give us the result whether the TB is positive or not positive, and also whether we are dealing with a rifampicin sensitive or a rifampicin resistant TB. All this happens within a matter of 2 to 3 hours. The other test which is done on the sputum is a culture. The results of culture take anywhere between 3 to 6 weeks to come positive. On a culture, if the culture is positive, that is a Mycobacterium TB, the organism of TB is grown, then we can test the sensitivity of various drugs to which the drug Mycobacterium is sensitive. So these are the basic two tests which are done as far as diagnosing TB microbiologically is concerned. Otherwise, depending upon the site of involvement, we do a radiological testing. For example, if the lung is involved, we can do a chest X-ray. If necessary, we may do a CT scan of the chest. If there is TB of the brain, we may have to do a MRI of the brain or a CT scan of the brain. If we are suspecting tuberculosis in the abdomen, then we can do a sonography of the abdomen or a CT scan of the abdomen. Depending upon the site of involvement, we plan the radiological investigations. So drug susceptible TB is when the tuberculosis, the organism is sensitive to the first line anti-tuberculosis drugs. The first line anti-tuberculosis drugs are 4: rifampicin, isoniazid, pyrazinamide, and ethambutol. So if we have a drug sensitive tuberculosis, the therapy goes on for a total duration of 6 months, out of which in the initial first 2 months, we give 4 drugs to the child: rifampicin, isoniazid, pyrazinamide, and ambutol. And in the remaining 4 months, we give 3 drugs to the child: isoniazid, rifampicin, and ethambutol, thus completing a 6 months of therapy. However, if the child is having tuberculosis of the brain or tuberculosis of the spinal cord, that is spine, then this therapy goes on for a period of total 12 months, that is 1 year. So drug-resistant TB is a problem which we are facing these days. What we mean by drug-resistant TB is the TB bacteria or the TB bacillus is resistant to the anti-tuberculosis drugs, the first line or maybe the second line anti-tuberculosis drugs which we are using to treat tuberculosis. The biggest challenge in diagnosing drug-resistant tuberculosis, or for that matter any tuberculosis, is The signs and symptoms of tuberculosis are very non-specific, which means there are many other disorders or diseases which can present with similar signs and symptoms. Secondly, retrieving a sample for testing. As we said in the previous section, that the sputum has to be retrieved from the child either by doing a gastric aspirate or by other means. This is a difficult procedure and a technically challenging procedure. The third one, even if we retrieve the sample, many of the times what happens is the test comes negative, and therefore we do not know. The microbiological test comes negative, and therefore we do not know whether we are dealing with a drug sensitive or a drug resistant tuberculosis. So these are all the challenges which we face in diagnosing not only the drug sensitive but also drug resistant tuberculosis. And once we are having a patient in whom we are suspecting drug resistant tuberculosis, it becomes very important to have a microbiological diagnosis. Unless and until we have a microbiological diagnosis, we won't be able to plan a proper treatment for that child. So as we all know, our country is a high burden setting, that is, we have a high TB burden. TB is a respiratory infection, which means it is spread from one person to another through the way of droplets. So the preventive measures which have to be taken to prevent the transmission of TB in children, not only in children but in any individual, is one, you have to practice cough etiquettes. If a person is having cough, he or she should cover his nose and mouth while coughing or sneezing. Second, whenever we are roaming around in crowded areas where there is a high population density, it is always better to have our face and nose, our nose and mouth covered with a mask so that the transmission does not occur to us. Third, if we have a case of pulmonary tuberculosis in our close contact, it is a good practice that we always, the case as well as the persons in the close contact with the case, wear a mask when we are dealing with the case, and if possible, isolate the case for the initial 2 to 3 months till the time anti-TB medications act. Fourth, but not the least, nutrition plays a very important role in the fight against tuberculosis. So we have to have our balanced diet regularly so that our body develops immunity to fight against not only TB but many other infections. And fifth, BCG vaccination is also practiced. It is given at birth. All the newborns who are born have to get BCG vaccinated right at birth. The advantage of BCG vaccination is it protects the child against the more serious forms of tuberculosis like the brain TB and the disseminated tuberculosis. These are certain few measures which we can practice to avoid transmission of TB in children. The message which I would like to share is, yes, we are living with tuberculosis, but there is no need to get scared with the disease. If we practice good preventive measures, then it is very easy to avoid getting this disease. And if our child gets any of the symptoms like fever or weight loss or cough or any other symptoms which are lasting for more than 2 weeks, it is always better to take the child to the doctor and get the child evaluated for tuberculosis.